Okay, now is our last speaker of this session, Dr. Xiaochen Zhang. Dr. Zhang is an assistant research fellow at the neuroimaging core of the Shanghai Mental Health Center. His research focused on developing non-invasive biomarkers for diagnosing and predicting outcomes in psychiatric disorders. He's currently a key researcher in the China Brain Project, which partially supports the work he is about to present today.
Thank you for the hosting. This is Xiaochen Zhang from the Neuroimaging Core at Shanghai Mental Health Center. Today, I feel very happy to share with you our latest work on whole brain mapping of GABA and glutamate dysregulation in patients with major depressive disorder. Major depressive disorder, or MDD, is among the most common and disabling psychiatric conditions worldwide. Its high prevalence and burden underscored the urgent need to clarify its neurobiological mechanisms for more effective and targeted interventions. However, the neurobiology of MDD remains largely unclear. Glutamate and GABA are two key neurotransmitters that play central roles in excitatory and inhibitory signaling, and they have been increasingly implicated in MDD. Imaging studies using MRS and PET have shown abnormal GABA and glutamate transmissions, supporting an imbalance in excitatory and inhibitory signaling that may underlie depressive symptoms. However, most prior studies are region-specific, focusing on isolated brain regions. Therefore, the spatial patterns of GABA and glutamate alterations in MDD are still lacking, and this problem limits the system level insights. And these gaps call for more spatially resolved investigations, which we attempted to address in this current study. Here, we used a fast, high-resolution MRSI technology called SPICE, which could map the whole brain glutamate and GABA concentrations at 2 by 3 by 3 millimeter resolution within just 10 minute scan. This technique gives us an unprecedented capability to investigate the distribution and changes of the excitatory inhibitory imbalance of MDD patients across the whole brain simultaneously. For more technical details, please refer to our recently published Nature BME paper by our collaborative teams, Professor Zhipei Liang from UIUC and Professor Yao Li from SJTU. This preliminary analysis included 39 MDD patients and 28 healthy controls. They were demographically matched. The patients included those who were drug naive and in their first episode, and those who were under a stable medication. To analyze regional neurotransmitter concentrations, the map of each participant was postulated using the DK atlas and the ASEC atlas. Then we conducted a region-wise analysis separately for each neurotransmitter, controlling for age, sex, and neuronal integrity, and applied forced discovery rate correction to account for multiple comparisons across both cortical and subcortical regions. Okay, let's begin with GABA alterations in MDD. Patients with MDD showed significantly higher GABA concentrations in several regions, including the left rostral anterior cingulate, right insula, lateral frontal regions, left and right, and right lateral temporal and parietal cortices and right medial occipital cortex. These findings seem to differ from earlier reports of lower GABA in MDD, and pointing to a more complex and regionally heterogeneous pattern of GABAergic dysregulation than previously thought. In contrast, glutamate levels are lower across multiple regions in patients with MDD, including the bilateral insula and posterior cingulate, parts of occipital, superior frontal, lateral temporal, and motor cortices, as well as thalamus and striatal structures. These patterns suggest that glutamatergic disruption is also spatially selective rather than global, like GABA, but exhibiting and distribution pattern distinct from that of GABA. And we also examined the glutamate to GABA ratio and index of local excitatory inhibitory balance. This ratio was significantly lower across most cortical and subcortical regions in MDD, suggesting a general shift away from excitatory dominance in MDD. Importantly, the basis of this shift varied across regions, with higher GABA driving the imbalance in some areas and lower glutamate in others. This finding suggests that distinct mechanisms may underlie the excitatory inhibitory imbalance in MDD. Next, we explore the spatial correlational structure of these changes. Unsupervised clustering revealed distinct alteration profiles separating metabolic and glial markers from news transmission-related changes. GABA and glutamate patterns were not correlated spatially, indicating that the excitatory inhibitory imbalance in MDD is regionally heterogeneous and likely reflects certain circuit-specific mechanisms. And these findings also highlight the value of the whole brain high-resolution imaging beyond conventional region of interest approaches. Within the MDD group, we found that GABA concentrations were negatively associated with depression severity across frontal, temporal, occipital, and motor cortices. Although GABA levels were generally higher in MDD, patients with more severe symptoms had lower levels, closer to those of healthy controls. This seems surprising. The precise explanation for this paradox lies beyond the scope of this preliminary analysis. One possibility is that it may reflect treatment effects, given that some antidepressants are known to increase GABA levels. And alternatively, stronger GABA may represent a trait-level vulnerability where shifts toward neurotypical levels could signify a disruption of internal coherence, which potentially leads to higher depression. These speculations are to be examined in future longitudinal investigations. In summary, through the SPICE technique, we managed to map GABA and glutamate in MDD on the whole brain level. We found patients with MDD showed higher GABA and lower glutamate with distinct spatial patterns, along with a broadly reduced glutamate to GABA ratio, supporting the excitatory inhibitory imbalance with region-specific mechanisms. GABA levels also negatively correlated with depression severity, possibly reflecting treatment or trait-related effects. This finding may inform future circuit-based interventions and longitudinal research. I feel genuinely happy and deeply grateful to have worked with our outstanding collaborators from SMHC, SJTU, UIUC, and NIH. We welcome further discussion, and please feel free to contact the director of our neuroimaging core, Dr. Ying Tang. Thank you very much for your attention.
Very interesting talk. So we have a couple of questions online. The first one is, what is the cost associated with this new scanning paradigm regarding the equipment, time, personnel, etc.?
The time, I think I've mentioned here, it's a 10-minute scan, and the cost.
Like, do you need special equipment for this? Do you hire people specialized in specific things to conduct the study?
Not at all. It can be performed. It can be performed as a conventional MRS, and we do not need special people, technicians, or special machines. This study collects data from a Prisma 3T scanner. Yeah.
Is the protocol open, accessible to folks who are interested in using it?
If you want to use this technique, you can contact our collaborators at UIUC, Dr. Zhipei Liang's team. Yeah.
Okay. And you mentioned in your study that you control for neuronal integrity. So how do you do that exactly?
Because the SPICE technique, based on the SPICE technique, we can get concentration levels on the whole brain level of several neurochemical substance, and one of them is the concentration of NAA, and we use that as an index of neuronal integrity. Yeah.
Okay. And another question, because in your results interpretation, you mentioned it's possible the unexpected pattern in GABA concentration might be due to the fact that the medications could change the effect. So the question is, were the patients that you scanned here on medication?
Oh, yeah. We have 39 patients here, and some of them, I think the number might be 15. They are in their first episode drug naive, and the rest of the patients are under stable medication. So in this preliminary analysis, we combined these two types of patients. But I think in the future, when the sample size enlarges, they will be divided into separate groups.
So you were going to have naive patients?
Yes, drug naive and medicated groups.
And what do you think is driving these neurotransmitter changes?
Oh, what's driving this? I'm not quite sure. That's the question. I think beyond the scope of this analysis, according to my speculations, there might be a treatment effect since the patients included in this study include patients that are under stable medication, and some of the medication are known to increase GABA levels, so that might be an explanation. And the other explanation is that because we don't know, this is a cross-sectional data, and we don't know if the patients here, when they were not depressed in the past, are they the same as the healthy controls we recruited here? It's a question we cannot answer and must be answered by future longitudinal investigations.
We have
Yeah, I think kind of tapping into some of those other questions. I was curious if you looked just at illness duration, especially in this sort of unexpected correlation. Like how long they've been sick for.
I beg your pardon, please.
Did you look at how long people had been sick for as a relationship between the GABA levels?
I'm sorry, I don't think we include that data. Yeah.
And also tissue type, like grey matter, white matter, the sort of structural as well as the NAA levels? Did you look at any of the structural?
Oh, you mean the concentrations of NAA? We use that metric as a covariate to control with, but specifically for the concentrations of NAA, the patients with MDD are significantly higher in NAA concentrations in several regions compared with healthy controls. Yeah, that's what we observed.
Very nice work.
Okay, since we're already a bit over time, I'm going to close the session, but just a quick reminder, please submit your review of the session through the app to help the speakers and organizers improve the program. Thanks for everyone to come to this session. Enjoy the rest of your day.